31 years of experience, and she has 42 publications to her credit. She's a member of the Specialist Board, NBEMS, and of the BLS and ACLS modules, and she's also the GC member and a member of ISA National Task Force for Fight Against COVID, and member of our National Task Force for CPR. She's also a member of the ROTO and SOTO for the committees of KM Hospital for transplants. And she is also the member of the critical care committee. And not only this, she's also into her cultural activities, and she's the winner of the Bharat Jyoti Award and Natya Kalaimani Award. So that's so great of you, ma'am. So over to you, ma'am, for your webinar.
Thank you so much for this wonderful introduction. Greetings from KM Hospital, and good evening to one and all. My humble obeisance to all of you, and thank you very much for inviting me for this lecture. Before the topic is on anterior mediastinal mass. So let me just first start share the screen. Yeah. Yeah, everybody can see the screen?
Yes, ma'am, it's visible.
Okay. So, see, whenever you come across a patient with an anterior mediastinal mass, I'm sure it will, bring in chills into your bones, because, when things go well, everything is okay, but things can suddenly worsen and the patient can collapse right in front of you, with you doing with you not being able to do anything at that point of time. So it's always better to be prepared and know what to do when things go bad, or when you expect that there is going to be a very bad case, which you would be doing. So the preparedness which comes with this case, with this particular case when you're doing, is very, very important. And I would be highlighting more upon that one, as well as the anesthetic considerations in this lecture. So the learning objective is to understand the anatomy of the anterior mediastinum, recognize the common presenting symptoms of anterior mediastinal mass, stratify the patient according to the risk based on symptoms and preoperative testing, anesthetic considerations, and the rescue plan during intraoperative airway or a cardiovascular collapse. So what is the anatomy? This is the anterior mediastinum. So it is spatially defined by the sternum anteriorly, the middle mediastinum containing the heart and the great vessels over there in the middle, and superiorly the thoracic inlet and the diaphragm inferiorly. You can see over here, this is the anterior mediastinum, this is the middle mediastinum, and this is the posterior mediastinum. What are the structures which can constitute in the anterior mediastinal masses? By and large, the thymus occupies the anterior mediastinum. So any thymic tumors or a cyst or thymic hyperplasia or a cancer of the thymus can first constitute the first T of the anterior mediastinal masses. The 4 T's are: first is thymus, second is thyroid, T-cell carcinoma, and teratoma. So they can be benign or they can be malignant. It can also, the masses can also arise from the lung, from the airway, pleura, pericardium, or even lymphatics. So some of the others which are common are cystic hygromas, which can plunge into the anterior mediastinum, thyroid carcinomas, as I said, seminoma, mixed germ cell tumor. We all know mixed germ cell tumor was there in one very famous actor who died. And also mixed seminoma was there in, I think, Yuvraj Singh. So it's not just that it's not so uncommon. Lymphomas also can be present. So the etiology of the antemediastinal mass in the descending order of frequency is lymphoma first, thymoma, germ cell tumors, metastatic lesions, bronchogenic masses, and thyroid. So let us look into one case, which I had done about 10 years ago, I would say. She was a previously healthy 55-year-old woman for thyroid surgery. She had compression symptoms, as in dyspnea, cough, etc., especially when she was lying down. She would say that I'm okay if I'm sitting, but the minute I lie down, I start getting breathless and I start coughing. Manipulation and retraction of the thyroid gland was required to come. So for this patient, because it was for thyroid surgery, a simple manipulation was done, and that the surgery was completed. Scooping of the thyroid gland done successfully without a need of sternotomy. The patient recovered uneventfully and was discharged to the ward on the same day. But to her horror, she developed cough and occasional breathlessness in the ward, the same way she used to develop earlier before the surgery. So she was wondering, I came here for the same symptom. I have got my thyroid removed, and now again the same problem immediately after the surgery. But then, we said, oh, maybe she is little psychic. Probably there's some problem with her. That's the reason she is saying, she's having breathlessness and cough. Now that the thyroid is removed, from where you will get the breathlessness? However, she complained of breathlessness. She was very persistent on that. But she wanted always the head end elevated. She was discharged on the 5th day. After a week, the patient returned to the hospital with worsening cough, dyspnea, and bloating of the face. Patient was tachycardic, hypertensive, with oxygen saturation of 89 to 90%, and she needed oxygen of 4 liters per minute to maintain a SpO2 of 94%. And during the frequent bouts of coughing which she had, the SpO2 dropped even less than 85%. And severe orthopnea required the patient to sit fully upright. A chest radiograph was done. And to all our horror, we saw that there was a large anterior mediastinal mass, which was probably compressing the trachea for more than 50% and the heart. So this X-ray was indeed done, but so there was a thyroid mass, and the anterior mediastinal mass was not not so prominent in the previous X-ray. However, and we thought it was just a small retrosternal extension of the thyroid, and then now we see a proper anterior mediastinal mass, and if you see that there is almost a 50% compression of the trachea. Now, we did a CT of the patient. There was severe tracheal compression. There was heterogeneous mixed density mass lesion lying over the brachiocephalic confluence over here, SVC, right atrium, and right ventricular outflow tract without any pericardial or pleural effusion. So it was sitting on the heart and some of the great vessels. An arterial cannula was placed in the right radial artery, revealing a 30 millimeter pulsus paradoxus. She was urgently being evaluated for resection of the mass, and a sternotomy with a CVT standby was planned for complete excision of the mass. Now, we did the mass all right. So we have to do a good preoperative evaluation in this case. So what is the aim of preoperative evaluation in the case of anterior mediastinal mass? You have to evaluate the risk for perioperative complication. So in the earlier case, you must have asked, you can ask me why CT scan was not done at that time. The surgeon felt that the CT scan need not be done as he felt it was just a small retrosternal extension, and probably that was the culprit for the airway symptom, and we can once we remove it, I think she should be all right. Let's not go for that CT scan. That was the surgeon's call. So now in any preoperative evaluation, depending on the patient age, nature, and location of the mass, as well as presence or absence of symptoms, the associated comorbidities will vary greatly. So first thing is to identify those with cardiorespiratory compressive symptoms and its exaggeration with exercise and positioning. Airway compression, it can compress the main trachea or the main stem bronchus. And when it does so, you will find that there is dyspnea, cough, hemoptysis, stridor, tachypnea, and cyanosis. The patient, if the obstruction is large enough on the heart or the vessels, you will find the patient can have SVC syndrome, where there is obstruction to the venous drainage. So the symptoms and signs are head, neck, or upper extremity swelling, swelling of nasal passages and larynx, causing stridor, cough, hoarseness where recurrent laryngeal nerve is involved, dysphagia, and dysphagia when there is involvement of the esophagus, or even visual disturbances. So any compressive effect can be exacerbated by GA. So that you have to be very, very careful. Extrinsic compression, which is by and large, many a times it is positional, and once these compressive symptoms are there, it should alert you that there can be a potential complication when you are going to anesthetize the patient. So then next is evaluation for risk for perioperative complication. As I said, the patient can have chest pain, hypotension, orthopnea, dyspnea, dizziness, syncope, all of them which are postural, fatigue, and sometimes even pericardial effusion, depending upon what kind of mass is there in the patient. Cerebral edema could be there even when there are huge tumors, where the patient will present with altered mental status, headache, vomiting, diaphoresis, all of them suggesting raised ICT. Systemic symptoms in a lymphoma may be associated with fever, night sweats, and weight loss. The thymic tumors with myasthenia gravis, patient will have ptosis, diplopia, bulbar muscle weakness, where there will be pharyngeal and the laryngeal muscle weakness, skeletal muscle weakness showing increased weakness with exercise. When the patient has pharyngeal and laryngeal muscle weakness, please remember these are the patients for high risk of pulmonary aspiration of gastric content. Thyroid masses can present with or without hyperthyroidism. Frequently, the only symptom may be chest pain or fullness in the neck. What additional information do you need to optimize in the preoperative period? And what is the significance of the symptom? The most important is which position decreases or improves the symptom of breathlessness. Is it head elevated, prone, lateral decubitous position? Once you know which position decreases the symptom, remember that is the rescue maneuver you are going to use as part of your anesthetic plan if any worsening occurs. How long you can lie flat? How many seconds, minutes, or you can lie flat in infinity? That's another question you have to ask. Paradoxical decrease in blood pressure occurring with a change in position from upright to supine because significant obstruction to the right ventricular filling or ejection will happen. A plethora of head and neck and prominent cutaneous veins suggesting SVC syndrome and that causing jugulovenous distension. Or other significant information is whether the patient has undergone radiotherapy or chemotherapy and its implications, like its systemic implication, or most important to us being airway edema. Again, cancer patients should be evaluated for the 4 M's. That is mass effect, metabolic abnormalities, metastasis, and medications. So what about the mass effect? Compression of the tracheobronchial tree, pulmonary artery, SVC or esophagus, obstructive pneumonia, lung abscess, Pancoast syndrome, recurrent laryngeal nerve or phrenic nerve paralysis. Metabolic abnormalities, as you can see in Lambert-Eaton syndrome, hypercalcemia, hyponatremia, Cushing syndrome, and myasthenia gravis. Metastasis to the brain, bone, liver, and adrenal. And medication, example, bleomycin or mitomycin C, doxorubicin or cisplatin. So if you see, bleomycin will cause pulmonary fibrosis. So here you cannot give 100% oxygen to the patient. So it causes pulmonary fibrosis. Mitomycin C is nephrotoxic and cardiotoxic. Doxorubicin is extremely cardiotoxic, and cisplatin is extremely nephrotoxic. So you have to look into the heart and the other kidneys and the counts and platelets and everything. All this depending upon which medication, which chemotherapy the patient has received. If there is tracheal compression, as in my case, you have to do a functional bronchoscopy. More than 50% decrease in tracheal main stem bronchial compression with cross-sectional area more likely to be symptomatic, leading to fatal intraoperative airway compromise, and positional relationship of the mass to the airway to be determined, so that the plan is to have a plan for GA or even to avoid GA, as the case may be. If there is a if there is a tracheal compression, what could be the catastrophic combination? If the tracheal compression diameter is more than 30 to 70% of normal with coexisting bronchial compression, then you're asking for a lot of trouble. And the other one is combination of left main stem bronchial compression. The mass is compressing the left bronchial tree and also the right pulmonary artery, which means there is no ventilation and no perfusion also. So, so it will be a total collapse of the patient the minute you start giving anesthesia to this patient. What investigation to be performed in this patient? Have to do a complete CBC, metabolic profile as an ABG, electrolytes, serum biochemistry, coagulation profile. If you're planning also to give thoracic epidural, you still need it. Even otherwise, also for general anesthesia, you need it. EKG, X-ray, of course. X-ray, you will find that there is a huge mediastinal mass and the retrosternal space is getting obliterated slowly because of pushing of the middle and the posterior mediastinum. So CT scan with IV contrast is indicated in these patients. So you will find that there is a mass here. This is a mass. This is the mass. Static assessment has to be done. Extension and effects on cardiorespiratory structures, as in level and degree of compression of the trachea, bronchus, the heart, and the great vessel compression, and presence or absence of pleural or pericardial effusion. So here in this case, look at this case. This was not my case, but it was almost similar to this. The great vessels are displaced to the left of the hemithorax. You can see it. See, these are the great vessels which are pushed. There is dilatation of intra-abdominal IVC, hepatic vein. So there is reduced venous return in this case. So what would be a plan? See, the minute you give general anesthesia to this case, you can never predict the dynamic changes which can occur. So the crux of the whole thing is you have to anesthetize the patient awake and keep the patient breathing till you're able to get the tumor, either the tumor removed, or you can bypass the the constriction. So this will give you all the necessary information for your anesthesia plan. A 2D echo is also very mandatory. So you have to know the myocardial function, degree of cardiac and great vessel compression, whether there's pericardial effusion, and degree of pericardial extension of the mass. PFTs have to be done. So this patient can have mixed obstructive and restriction if it compresses both the lung parenchyma as well as the bronchi. A fixed obstruction in the flow volume loop, you will find that both the inspiratory and the expiratory excursions are similar. Whereas there is an intrathoracic airway obstruction, it is accompanied by widening of the mid-expiratory plateau. See this. This is widened, okay, with in the airflow, a decrease of more than 10% from the sitting to the supine position is considered very significant. So an intrathoracic mass will flatten the expiratory upper limb as it obstructs the airway during the expiratory part of the expiration part of the breathing. Other investigations are pleural cytology, bone marrow aspiration, biopsy of the mass, MRI. If allergic to dyes or patients with CKD, then you need to you do an MRI, a technetium-99 scan, or test to determine neurohumoral effects, as in if there is presence of thymus or a carcinoid as the anterior mediastinal mass. The surgical approach is, of course, sternotomy or a thoracotomy, cervical mediastinoscopy, anterior mediastinal copy, or a VATS surgery. So how will you stratify patients according to the risk based on symptoms and preoperative testing? Those with high risk, low risk, are very mildly symptomatic or maybe even asymptomatic with postural symptoms or radiographic evidence of significant compression of structures. The intermediate risks are the people who have mild to moderate postural symptoms with a tracheal compression of less than 50%. And those with high risk have severe postural symptoms, stridor, cyanosis, tracheal compression which is more than 50%, or tracheal compression with associated bronchial compression, or pericardial effusion, or SVC syndrome. What is the urgency of the surgery? It is emergent if the patient is showing obvious signs of airway obstruction or a cardiovascular collapse or impending distress directly related to the mediastinal mass. You have to take up this patient immediately. It is urgent when the patient is becoming increasingly symptomatic or is requiring increasing support in terms of cardiovascular or respiratory decompensation. Also, the mass may become increasingly difficult or impossible to resect surgically if allowed to grow any further. And it can be elective if the patient is coping well or is asymptomatic, but the mass has a negative impact on quality of life. The mass may be manageable with other treatments prior to surgical resection, including medical, radiation, and/or chemotherapy. So here it is elective. You can wait and do it at a later date because otherwise the mass can grow, keep growing, and the symptoms will torture the patient. So you need to have a multidisciplinary approach with the involvement of anesthetist, surgeon, and if it is a child, a pediatric surgeon, cardiologist, cardiac surgeon, ENT surgeon, intensivist, oncologist, intervention radiologist, and radiation oncologist, depending upon what type of mass the patient has presented. Who should be present during induction of anesthesia in this case? Anesthetist, surgeon, a cardiothoracic surgeon, a perfusionist, or an ENT surgeon. I will come to you why we need the cardiothoracic surgeon and the perfusionist. So what are the issues affecting the management? One is there is a competition for the mediastinal space with the vital structures like the heart, pulmonary vessels, great veins, lungs, and major conducting airways. The triggering factors following induction of anesthesia and supine position on the table and associated interventions such as neuromuscular blockade and positive pressure ventilation exert profound effects on this balance, and you can lose the airway. Associated tracheomalacia is there, airway obstruction is imminent. So what are the issues which affect the management? A diminished cardiac output due to direct compression of the SVC, pulmonary arteries, or the heart itself. Airway swelling because of the compression of the tumor. Patient may present with laryngeal edema due to the SVC syndrome. Remember, in such a patient, you cannot extubate on table. You have to wait for a good 48 hours, give steroids, give good nebulization, and extubate the patient. The decrease in cardiac index is primarily due to an increase in right ventricular afterload, the end result of which was decreased left ventricular stroke volume by an effect on ventricular interdependence. So basically, there is no venous return. The right ventricular afterload is also affected, and based on the ventricular interdependence, even the stroke volume gets affected. Tamponade-like effect by impeding the diastolic filling of the cardiac chambers, exacerbate cardiac effusion, and of course the side effects of radio and chemotherapy if the patient has had a bleomycin-based or a patient has had doxorubicin-based, patient may have a cardiomyopathy or stunned myocardium and things like that. So you have to be very careful in these patients. What would be your anesthetic technique for a CT guided biopsy? Now we have come to a NORA, that is a non-operation rooms anesthesia. So here you don't have all the luxury of an operation theater, right? So if the surgeon, please excuse me. So what would be your concern? So if the surgeon says, I want to do a CT guided biopsy, what are your concerns? Well, exactly, it is a risky anesthesia. It has to be done under local infiltration anesthesia. For intermediate and high-risk patients, you have to avoid GA. LA with or without sedation. I would say if you want to give sedation, give dexmedetomidine sedation. Radio or chemotherapy and steroids prior to shrink the tumor so that histological accuracy of T-cell lymphoma is affected and symptomatic relief is there once the tumor is shrunken. Awake VATS can be done with epidural anesthesia or a erector spinae block with a paravertebral block. Thoracic paravertebral block combination provides effective intraoperative anesthesia and postoperative analgesia. So you can try this in a patient who wants a CT-guided biopsy. The cough reflex is aborted with narcotics. And today we are getting remifentanil in the market very shortly. That will be the narcotic of choice. Because the minute you stop remifentanil, within 4 to 5 minutes, the effects are reversed. And you can have the patient not being overly sedated. And if feasible, if you find the patient is tolerating the procedure well, you can think about propofol, provided the mass is not very big and it is not giving compressive symptoms, and it is less than 50% of the diameter of the trachea. Intercostal nerve blocks also have been tried. Masses with anterior and superior mediastinum are readily accessible using a small anterior mediastenotomy approach under local anesthesia. Mediastinoscopy and thoracoscopy can also be performed under local anesthesia in motivated patients at the second intercostal space. You have to monitor the right-sided pulse for compression of innominate artery as well as the peak airway pressure. In patients with severe airway compromise, whose treatment is non-surgical, airway stenting can be performed as a temporary measure. So in my case, as I said, because the compression was more than 50%, if the surgeon said, I want to do a biopsy, I would always say, please go for a stenting. But still, the airway is secure, but what about the vessels? So therefore, the patient has to be awake. And here again, remember you have to know in what position the patient is more comfortable. That will be your what do you call, your thing to recover, to get the patient to put on that position so that the patient is able to breathe and the patient's cardiac output to recover. So remember the importance of this history in your preoperative evaluation. What is the main risk associated with GA? We all know that the GA causes a fall in FRC, isn't it? So the lung volumes are reduced under GA, and relaxation of the bronchial smooth muscle leads to greater compressibility of the airway from the overlying mass, isn't it? The muscle relaxant induces paralysis of the diaphragm, reduces the normal transpleural gradient, and dilates the airway. This decreases the caliber of the airways and enhances the effect of the extrinsic compression of the patient. So therefore, GA is extremely dangerous. As the depth, so increase in the airway diameter with compression of the mass may lead to an airway collapse. The fall in FRC by 20% affects on inspiratory intercostal muscle tone, elastic recoil of the chest wall, and the Kevlar displacement of the diaphragm. A small airway collapse with GA can further impair the oxygenation. Increasing the depth of anesthesia has negative inotropic effect, which leads to cardiovascular collapse, and neuromuscular blockers can aggravate all of the above by inducing relaxation of the chest wall, neck, as well as the supraglottic structures. So what is the effect of positive pressure ventilation in these patients? The loss of spontaneous ventilatory activity decreases the transpleural pressure gradient, which under normal conditions serves to distend the intrathoracic airways and prevent the collapse. So you will find, when the patient is breathing normally without any muscle relaxant, when there is a negative pressure breathing, you will find that somehow the airway is trying to open up. Whereas the minute you institute a positive pressure ventilation, see how progressively it starts collapsing. What is open like this now becomes smaller. So this is what happens when you start giving positive pressure ventilation. There is loss of normal negative intrathoracic pressure due to the positive pressure ventilation and increases the risk of compression of the airway, heart, and the great vessel by the tumor and causes diminution of the venous return. If GA is planned for a large anterior mediastinal mass, what would you do? Here is where our plans have to be set right. Have a rigid bronchoscope and a skilled ENT surgeon standby. Jet ventilation should be present. A cardiothoracic surgeon should be there because at that moment when you're not able to neither ventilate or oxygenate the patient, nothing will help no one can help you except a cardiac surgeon, because he has to do an emergency sternotomy and immediately lift the tumor to abort the compressive effects if everything fails. If the ENT surgeon fails, then it is the cardiac surgeon who has to come to your rescue. Otherwise, the next important thing you can try to do is take the patient on the side on the side and see whether the compression is getting relieved. But I'm sure it's not going to get relieved most of the time. So it's always better to have a cardiac surgeon and an ENT surgeon standby when you're doing a complicated case. What would you monitor? A standard heart rate rhythm, SpO2, EtCO2, temperature, respiration. To this, you have to step up your monitoring. by having invasive blood pressure monitoring, CVP, urine output, airway pressure on the ventilator. If there is there is increase in intracranial tension, as in very huge myasthenic tumors, you also have to monitor ICP. TEE, if present, will be great. You'll know the ventricular function, the tumor compression, and also you'll be able to also manage the IV fluids and vasopressors on a live basis, and depth of anesthesia monitoring and neuromuscular blockade monitor if muscle relaxant is being used. What would be your anesthetic technique? First, have wide bore IV in the lower limb in presence of SVC syndrome. Femoral line in very high risk cases, as the upper caval flow may be occluded, as well as the IJV. So have a femoral line in C2. Avoid pre-medication in patients with cardiorespiratory symptoms. How would you induce anesthesia? So here is a patient. The technique of induction and intubation depends on the site and extent of the tracheobronchial tree compression or the compression of cardiovascular structures. And I wouldn't mind repeating to say that awake fiber optic intubation is the safest. So that can be performed under local anesthesia. It permits real-time inspection of level of obstruction, the diameter of the airway, the dynamic airway collapse, as well as the mass effect. In a low resource area, inhalational induction with sevoflurane can be tried. IV induction judiciously with the KET propofol mixture or using dexmedetomidine, remifentanil mixture. Well, these are analgesics with minimal respiratory depression, but then the patient can be sedated for a long time. So maintain spontaneous ventilation with LMA. You can even try that, second generation Procel, iGel, or a Supreme LMA, and intubation if cardiopulmonary bypasses needs to be instituted. So initially, you can even try a spontaneous ventilation with LMA. Avoid risks of upper airway obstruction like breath holding, laryngospasm, etc., which may be detrimental in the presence of tracheobronchial obstruction. And in these cases where there are huge tumors, as far down as T4, you can use microlaryngeal tube to go past the tracheal compression. Double lumen tubes, bronchial blockers can have been used for VATS. Maintaining spontaneous ventilation and avoiding paralysis is the key in high-risk patients. If muscle relaxation is necessary, short-acting succinylcholine tried first, and short-acting muscle relaxant non-depolarizers if definitive airway and ability to ventilate are certain. Positive outcomes of
Madam, please unmute. We're not able to hear you, ma'am.
somebody muted me also. Are you able to hear me now?
Yes, ma'am. Now. Okay.
So with spontaneous ventilation, the mediastinal pressures are significantly low. Yes, so you can use modes which involve spontaneous ventilation. You can use spontaneous ventilation via LMA or a reinforced endotracheal tube or a microlaryngeal tube. And as I said, you can in one lung ventilation, if you want to give one lung ventilation, you can use double lumen tube or a bra. Readiness for emergency airway measures, the ventilation of the mask, rapidly awakening the patient and shifting the patient to a pre-planned rescue position, or utilizing rigid bronchoscopy for ventilation. Thank you for you. Able to move the slide. Okay. Okay. So in the rescue position, once you have avoided a rescue position, there's a mild to moderate decrease in cardiac output and may respond to a lightened depth of anesthesia and the basic principles of cardiac tamponade management, including plasma expansion and or treatment with vasopressors or inotropes. So the minute you find that there is the BP is coming down in these patients, there is compression. The minute you remember that, please get back to the rescue position, start running fluids and vasopressors to the patient. Unresponsiveness to this measure will require an immediate sternotomy, and you have to ask the surgeon to take over. Thoracic epidural or a paravertebral block can be given. Use of regional anesthesia can attenuate the neuroendocrine response, facilitate rapid extubation, and improve ventilatory mechanics secondary to decreased narcotic requirement. So these
Madam,
your
screen is not visible now. Your screen is not visible.
Not visible?
Yes.
Screen is not visible, ma'am.
Okay, let me see. 1 minute, let me check. One minute. 14. 1 minute, let me just log back again. 1 minute, please. I'm trying to share screen again. Okay. Because somebody, muted everybody.
Okay. Now it's visible, ma'am.
Yeah. Now is it visible? It's visible, right?
It's visible, ma'am, now.
So you could hear this slide. Thoracic epidural with paravertebral block.
No, madam, please repeat.
So,
no, ma'am.
Okay, so I've come to thoracic epidural. I'm done with general anesthesia. I'm coming to thoracic epidural and or a paravertebral block. So what are the advantages of this? The patient is breathing spontaneously. It can attenuate the neuroendocrine response. It can facilitate, even if you're using it with G8 extubation, and improve the ventilatory mechanics, secondary to decreased narcotic requirement. Or a T4 or a T5 epidural placement, you can do a segmental epidural anesthesia from T1 to T6 with inhalational induction or a local anesthesia. So you can do a thoracic under local, right? Main analgesic technique, even if you can consider that as a main analgesic technique in order to maintain spontaneous breathing. The other technique of regional anesthesia is erector spinae block with paravertebral block. So that can be done under ultrasound guidance. So you can do both an erector spinae, this is the paravertebral space. So you can do erector spinae block or along with paravertebral block. So combination of both with mild sedation is safe. It provides excellent postoperative analgesia, and intercostal nerve blocks. Alternatively, intercostal nerve blocks have also been tried, but keeping the patient not from coughing is very difficult with only intercostal nerve block. LA absorption is very high and can reach toxic levels if you're not careful with intercostal nerve block. Let us come back to the case. The airway pressure is continuously high. Now you have seen the patient airway pressure is going up and the patient desaturates despite attempts at bronchoscopic adjustment of the endotracheal tube. The surgeons are scrubbing. Now, what would you do? Because now the airway pressures are high and the patient saturation is coming down to 70, 60. So here you have to alert the surgeon. I'm repeating, try rescue postures, endobronchial intubation with reinforced tube, urgent rigid bronchoscopy and jet ventilation, immediate sternotomy to lift the mediastinal mass. The airway pressures and the saturation will now improve dramatically. The other way of doing it, if you have a heliox in your machine, is you can use heliox, because in a critical airway obstruction, it can promote laminar gas flow and it can improve oxygenation, and it provides symptomatic improvement as well as facilitate the induction of general anesthesia and weaning from the ventilatory support. So the final option in these patients is to have a femoral bypass or a cardiopulmonary bypass. If the tumor compresses the distal third of the trachea, both the mainstem bronchus or the carina, then you please do a femoral bypass in this patient, because both the mainstem is blocked, trachea is getting blocked, as well as the carina is also getting blocked. Better be prepared with the cardiac surgeon, or the extension of the right heart or pulmonary artery with significant risk of hemodynamic collapse after induction. It should always be established elect and a cardiac surgeon and perfusionist in the operating room. The ischemic interval during emergent cannulation and institution of full bypass is likely to result in significant neuronal injury. So you have to be prepared with the femoral bypass, with the proper, priming of the circuit. Surgical exposure of the femoral vessels, so cannulation is done in these patients preoperatively. So what is your extubation plan? Airway obstruction secondary to laryngeal edema can occur. Long-standing masses, tracheomalacia can be there. Patient can have phrenic or recurrent laryngeal nerve palsy. Atelectasis can be present in these patients. Massive blood loss can occur with removal of these large masses. So with all this,
Not able to hear, madam.
Madam, there's a pause.
you can extend the same epidural or the paravertebral block or erector spinae block. All of them can give you a good pain relief in these patients. So in summary, large anterior mediastinal mass presents a considerable challenge to an anesthesiologist. Avoidance of general anesthesia for diagnostic procedures is recommended, particularly when symptoms are severe. Maintenance of spontaneous ventilation with GA is the cornerstone of management in high-risk patients. And high-risk patients requiring general anesthesia for resection require a careful, individualized anesthetic plan with multiple therapeutic options readily available to prevent or manage the cardiorespiratory complications. Thank you very much.
Excellent presentation, ma'am. It's such a difficult topic made easy by you. You have dealt with every aspect of the topic. So though it's a rare case and it is a very threatening case. So at least now we should be alert, yeah. So thank you very much, ma'am, for the excellent presentation. Any questions are invited. There was one question somebody talked about, was asking about the rigid bronchoscope. What is the role? You, after the question was asked, you have discussed that, ma'am. So if you just want to take it up again, the question is, what is the role of bronchoscope in this case, ma'am?
So especially when there is a tracheal compression or a bronchial compression, A rigid bronchoscope, the minute you give, see, even if you're maintaining spontaneous ventilation, as long as you're maintaining spontaneous ventilation, everything is fine. The minute you give, supposing you've given scoline, say, and you have lost the airway. So what are you going to do? It's going to take a full 8-10 minutes, right? So you ask the ENT surgeon to put in a rigid bronchoscope so that you're able and use your jet ventilation at that point of time and ventilate. So you can oxygenate the patient in these cases.
So the topic is very clear and to the point. I don't think we have any other questions, ma'am. So anybody has anything
What's
to
the
add?
inhalational drug preferred?
Good evening, madam. Indrani, madam. Congratulations. Very tough topic. You made it very simple.
I know.
Thank you.
Made
very
easy.
Please elaborate something about stenting of airway.
Yeah. So nowadays we have tracheal stents. Bronchial stents are available. So the radiology, usually the radiologists do this procedure. That can be, you can use a stent because of compression. So this will keep the airway open, you know.
Yeah.
If there is a large compression.
Madam, some water.
Good.
I'm so sorry. I've been suffering with chronic bronchitis.
We are thankful to you, madam, take up this presentation without postponing. You're putting a lot of effort because of your health.
No, not at all.
Okay,
My pleasure. Come on. It's always my pleasure to be part
the
of
float
your
is so bad,
webinar.
ma'am, but in spite of that, you have done it. So that's great.
So, so when you see, when the cross-sectional area is more than 50% compression, right? And so in these cases, it's always better to stent. Stent the airway and then take the patient.
Okay, madam.
The next question, ma'am, what's the inhalation drug
about
preferred
the
in such
inhalational
cases?
agent of choice, right? Inhalational agent of choice.
Yes.
I would always go for a sevoflurane induction, obviously, for obvious reasons. Sevoflurane is the best for induction. Of course, you prime the patient with dexmedetomidine, giving 1 mics, 0.7 to 1 mic per kilogram. And first, you have to prime the patient with dexmedetomidine and start taking on sevoflurane.
Okay. Anybody wants to add anything, can please do.
I request Dr. Deepraj Singh, sir. He is our senior faculty and he worked long time in ENT hospital as well, tertiary ENT hospital. Sir.
Good evening, everyone.
Good evening, sir. Good evening, sir.
I have a couple of instances wherein I had to anesthetize these cases. One thing is nowadays you have virtual bronchogram is there, wherein you can see the trachea. It's a non-invasive procedure, wherein you can exactly point out where the compression of the trachea is. This is called virtual bronchogram. What we usually do is in the ENT hospital when I was there. And this stenting procedure, because I was closely associated, in case of these tracheal compression with the mediastinal tumors, it is very difficult to dilate that portion. It is very, very difficult because it's a long-standing compression. It is easily said than done because I have been associated with this team. So stenting is also a little difficult proposition. I have anesthetized these cases almost in the sitting position, most of them, in 2 cases.
Right.
In the
That's
sitting
what.
position,
See, you have to see which is the rescue position.
Yeah, that's it. Fortunately, my height
The
is more,
rescue
so I could do
position,
it
the
easily.
importance of knowing the
Knowing the position, that is very
yes,
important.
importance of knowing your rescue position.
Yeah, in which position the patient is comfortable, you try to do all these
anesthetize at that position.
Anesthetize in the awake position. And now, time of we have veno-venous
bypass.
ECMOs.
Femoral bypass.
Standby, yeah, femoral bypass is always a standby and a rescue thing. what we can suggest before anesthetizing, you have to be prepared with this, because you can divide these mediastinal tumor into 3 categories: safe, uncertain, and unsafe. You cannot know when this safe patient may turn into unsafe position also. Once you anesthetize, they can go deteriorate very suddenly.
Absolutely. That's the message I was giving all the way, you know.
Even
So,
if the patient has very minimal symptoms of obstruction, but as soon as you try to anesthetize these patients, suddenly they deteriorate. So it's in this era of ECMOs, venovenous ECMOs, I think probably we have a standby. You take all these femofemoral lines and keep ready everything, and then you try to anesthetize this patient.
yes.
So that at least you will not, even if you successfully intubate these patients, you can never know if there is obstruction beyond distal to your tube. You can never know where the obstruction is. Fortunately, we had a few cases wherein virtual bronchogram was done, and we exactly know it was at the carina. So it was very difficult proposition to carry out this. Successfully, we could do it.
The only way out is to go on bypass in these patients.
Only on bypass. Only on bypass. All these
no other choice.
Very large tumors. Don't take any chances. Have a femoral bypass ready to operate in case you lose the airway. Probably immediately you can go on to the bypass, and then probably things.
Right.
Post-operative period also quite stormy, madam. Even if you remove the tumor also, post-operative for 48 hours, this patient has to be on ventilator and probably managed well in the post-operative period.
That's why I said, don't try to remove the tube.
Yeah, don't try to remove the tube.
Extubation can be done slowly. Yeah. Very true.
It is a very, as you said, it's a team effort and very meticulous and planning. Plan A, if it fails, plan B, if it fails, plan C. All these 3 plans has to be there beforehand.
Right.
Thank you, sir, for your valuable input.
Nice presentation, Madam Dr. Indrani.
Very
Thank
nice.
you, sir.
Thank you.
Thank you, sir.
On behalf of ISA Telangana, I thank Dr. Indrani Hemant Kumar for accepting our invitation, and I am very happy to be in the audience. Excellent presentation, madam.
It's my privilege, sir.
Yeah. And you are a well-known speaker in various conferences as well. So thank you, madam. In future also, we look forward to you to meet physically. Whenever we conduct some conference or some scientific program in Hyderabad, we will definitely invite you, madam. Thank you.
Thank you very much, sir. Thank you.
Thank you very much, ma'am, for this excellent presentation.
Thank you, Pavani. Thank you. Thank you, Dr. Deepraj Singh, sir.
Thank you, ma'am.
Thank you very much. Thank you, Dr. Ramkrishna Reddy. Thank you.
Thank you, madam. Thank you.
Okay. Thank you all the audience
you, one
also
and
for
all.
attending.
Yeah.
Yes. Thank you. Thank you, ma'am. Okay. Right, ma'am. Thank you.
Thank you.
అందరూ వెళ్ళే వరకు ఉండాలి, నేను హోస్ట్ కదా.
వెయిట్ చేస్తున్నాను.
ఇఫ్ ఐ క్లిక్ ఎండ్ ఇట్ విల్ బి ఎండ్, ఖతం అయిపోతుంది. నన్ను హోస్ట్ చేసేసి వెళ్ళిపోయాడు బషీర్.
Sir, you are at home and not in your what do you say? You were somewhere else, no, sir?
Farmhouse, as usual.
Farmhouse.
I am in farmhouse.
Still, you're residing there, sir?
I am living there only.
Acha.
After staying here, city at much I am not liking.
Then you're coming to college from there only, sir? You're coming to college from there only, sir?
Yeah, it's very near from here.
Okay.
It's like 20 minutes.
Okay, nice. So we'll also visit you, sir, sometime.
Yeah, I'll invite you once.
One invitation is pending, actually.
Long pending. So, it's a long pending.
Long pending. It will be fulfilled in 23.
Okay. How about the year end, sir? You are busy at the year end.
Not much. Busy with the daughter and granddaughters.
They are here, sir. Your daughter has come back now, sir.
Yeah, she's here only.
Yeah. Okay.
So So nice, Pavani.
Thank you also, sir. Thank you, sir.
Nice. Thank
Okay,
you.
Dr. Ramakrishna, shall we end? Thank you also.
Yeah.
Yeah, thank you. Okay, sir.
Okay, Pavani.
Thank you.
Okay.